continue from question number 11. Okay, so we have a 54-year-old man comes to the physician for evaluation of exertional chest pain. He first noticed the pain a couple months ago when he was shoveling snow off his driveway, and has since experienced several episodes while doing other strenuous tasks. He describes the pain as heavy crushing sensation and says it is relieved with rest. The patient undergoes coronary angiography and is found to have severe stenosis of the right coronary artery and left anterior descending and circumflex arteries. Remember, they are talking about more arteries, more in number, right coronary artery with LID and with circumflex artery. He is referred to a surgeon for coronary artery bypass grafting. During the procedure, a portion of his great saphenous vein is removed and grafted to one of the diseased coronary arteries to bypass its atherosclerotic narrowing. The vein used is a graft during this patient procedure can be assessed at which of the following sites. Sorry, I have answered it because my video was paused. Then again, I again started it. Okay, so at the mid line of the popliteal fossa, just inferior to the anterior superior iliac spine, just inferior lateral to the pubic tubercle. Then we have just superior to the inguinal ligament, over the lateral aspect of foot. Let us discuss that what is the reason that we can take this great saphenous vein just inferior lateral to the pubic tubercle. First, we look at the superficial and deep veins of leg. So we have dorsal venous arch, right? That would move in the above direction uh, and will continue and drain into great saphenous vein, right? And with that, it will drain into small saphenous vein. It will drain into small saphenous vein on lateral aspect of leg and on the medial aspect with great saphenous vein. That will drain into great saphenous vein, right? If you look over here, this is popliteal vein, right? That would give branches to um, this small saphenous vein. With that, we have like interior tibial vein and posterior tibial vein, and on the peroneal side we have peroneal veins, right? With it, like we have three vein popliteal vein that when it passes through adductor canal, that it would form femoral vein, right? With that, we have great saphenous vein, right? We have great saphenous vein and femoral vein, and with that deep femoral vein, they will merge at the common femoral vein, right? Let me move. Yeah, over here they are asking about this is great saphenous vein, this is femoral vein, and this one is deep femoral vein, and with that we have medial circumflex femoral vein, right? And with that we have lateral circumflex femoral. They will form what? Uh, First they will form common femoral vein. Okay, so when we move upward, when it is passing the inguinal ligament above, it will drain into external iliac vein. So above inguinal ligament we have external iliac vein. Below that we have common femoral vein, and then it will form great saphenous vein. Okay, so over here this is pubic tubercle. So over here we have inferior side of the tubercle and on the lateral side of the tubercle, right? So with the left anterior descending artery alone, LED alone is occluded by atherosclerotic plaque, the left internal memory thoracic artery, right? Thoracic artery is preferred vessel for bypass grafting due to superior patency rates, right? Then we would take graft from left internal memory, that is thoracic artery. However, when multiple coronary arteries are vessels, just like in this case, other than LED require revascularization, great saphenous vein grafts are routinely used, right? Great saphenous vein is located superficially in the leg, right? And is the longest vein in the body. This thing is important. Longest vein in the body is great saphenous vein. It courses superiorly from the medial foot, anterior to the medial malleolus, and up the medial aspect of the leg and thigh. Okay, in the proximal interior thigh, 3 to 4 centimeters inferior lateral of the to the pubic tubercle. We talked about this thing. This is inferior lateral to the pubic tubercle. The great saphenous vein dives deep through the cribriform fascia of the saphenous opening to join the femoral vein. Surgeons access the great saphenous vein in the medial leg are less commonly. Uh, this is most common region, right? While less commonly near its point of termination in the femoral triangle of the upper thigh, right? Just like in this case. The femoral triangle is bordered by inguinal ligament superiorly. This thing is important. Superiorly by inguinal ligament, sartorius muscle laterally, adductor longus muscle medially. We would talk about this in another case. Why not option E? The popliteal artery in vein course centrally through the popliteal fossa together with the tibial nerve. Common medical problems that occur in the popliteal fossa include popliteal artery aneurysms, which account for the majority of the peripheral artery aneurysms, and synovial, that is Becker cysts. This is important, which are commonly associated with arthritis. Association with arthritis, important. Becker cyst. Okay. So then why not option B? Because no major vessels are located immediately inferior to the interior superior iliac spine. ACS. The ACS serves is the superior attachment of the inguinal ligament. Okay, like this, just like that. This is the interior superior iliac spine. While over here, we have like a pubic tubercle, right? Close to this area, right? Okay. Then and a penetrating injury to the region below the ACS could damage the lateral cutaneous nerve of thigh. This is important regarding this. We would damage lateral cutaneous nerve of thigh if what we do if we do injure region below the inferior superior iliac spine, right? Why not option D? The deep circumflex iliac vessels course parallel to the and just superior to the inguinal ligament. The superficial and in the inferior epigastric veins course above the mid portion of the inguinal ligament. Talking about superficial and inferior epigastric veins. The deep circumflex iliac veins. Let's say if this is let me draw this. If this is the inguinal ligament, they would move just like this, parallel to the inguinal ligament, right? Yeah. So then why not option E? The small saphenous vein can be found in the lateral aspect of the foot. This vein courses posteriorly to drain into the popliteal vein, right? So the great saphenous vein is a superficial vein of the leg that originates on the medial side of the foot, courses interior to the medial malleolus, travel up to the medial aspect of leg and thigh, drains into the femoral vein within the region of femoral triangle, few centimeters inferior lateral. This is important. Inferior lateral to the pubic tubercle. Okay, moving to question number 12. A 63-year-old man comes to the emergency department due to pain and swelling of the right calf. He has a history of recurrent gastrointestinal hemorrhage and was discharged from the hospital 4 days ago following a prolonged admission for the diverticular bleeding requiring multiple blood transfusions. Temperature is 98 degree Fahrenheit, BP is 110 by 60 mm, EG pulse is 92 per minute, and respirations are 18 per minute. Compression ultrasonography with Doppler reveals deep venous thrombosis in the right popliteal vein. Okay, a filter placement. This is important. A filter placement is planned to prevent embolization. Okay, a section of the patient's abdominal CAT scan at the level of L2 is shown in the image below. The filter will most likely to be placed in which of the following structures? So they have mentioned this CAT scan. Option A, option B, C, D, and E. So pause it because they are respectively A, B, C, D. Pause it and give the answer. So the correct answer for this question is option B. Why? Let us see. Because it is the inferior vena cava. We will make this filter paper. We will plant that in inferior vena cava. Let us see to the explanation. First, let us know these things. We have this one. This is large bowel, right? And this one is the duodenum second part. Then this one is the pancreas, right? And this one over here is the liver, right? And with that, this is the duodenum fourth part, right? And this is the left renal artery, sorry, left kidney, okay. And with that, this is left renal vein, Let me show this for you. Yeah, so this one is left renal vein, right? And this one is abdominal aorta because this is at level 2, at L2 level, right? And with that we have this one. This is inferior vena cava, so option B is the right answer. And this one is the right kidney. Okay, so this was right kidney, left kidney, left renal vein, this one, right? Inferior vena cava, abdominal aorta, second part of duodenum, this one is liver, right? Okay, this patient with deep venous thrombosis has recurrent episodes of gastrointestinal hemorrhage, including a recent one requiring prolonged hospitalization given the risk of bleeding associated with anticoagulation therapy. In this patient, inferior vena cava, this is filter, inferior vena cava filter placement is planned. Inferior vena cava filters are designed to prevent the embolization of DVT from the legs to the lung vasculature, that is, will prevent pulmonary embolism, and are used in patients who have contraindications to anticoagulations. CT images are always visualized as though standing at the patient's feet. So we are looking at the patient's from the side of patient's feet and looking to the patient's body toward the head. Okay, therefore the left side of the image corresponds to the patient's right side. Okay, that means we are if let's say this is the guy. Okay, we are looking from this guy, right? So this one is the right side and this one is the left side, right? Both kidneys are viewed in this section. In the inferior pole of the right lobe, the liver is noted interior to the right kidney, and posterolateral to the large bowel. Yeah, the filter will be placed in the inferior vena cava, which lies medial to the descending part of the duodenum, right, and interior to the right side of the vertebral body. The common iliac veins merge to become the inferior vena cava, inferior to this plane of section at the L5 level. Why not option A with its dark center representing an air-filled lumen and mucosal folds? Structure is likely the second, that is descending part of the duodenum. Yeah. Okay. Second part of the duodenum, which typically lies at the level of L2. Why not option C? The structure represents the abdominal aorta, right? Which is on the left side, which bifurcates at the level of L4. Yeah, it will bifurcate at the level of L4. The structure is on the patient's left, so it is unlikely to be inferior vena cava because the inferior vena cava is on the right side. That would drain into the right atrium. Option D, that represent structure ascending part, the fourth, that is ascending part of the duodenum, right? This CT section likely captures only the wall of the fourth part of the duodenum, as it briefly courses transversely, located just like that, right? So transversely across the abdomen before descending is the jejunum. So the lumen is not visible, right? This structure they're talking about, option E, is the left renal vein, right? Which I talked about that. The left renal vein receives drainage from the left gonadal vein, right? And courses interior to the aorta but posterior to the superior mesenteric artery before draining into the inferior vena cava. Okay, so inferior vena cava courses to the abdomen and inferior thorax in the location interior to the right half of the vertebral bodies. The renal vein join the inferior vena cava at the level of L1, L2. Common iliac vein merge to become inferior vena cava at the level of L5. This is important. Inferior vena cava filters are placed in patients with DVT who have contraindications to anticoagulation therapy. Right? Now continuing question number 13. A 64-year-old man with type 2 diabetes mellitus is evaluated in the clinic due to occasional dizziness. His symptoms usually occur while playing table tennis. The patient has not had any falls or loss of consciousness, right? He has no known history of coronary artery disease or stroke. The patient has smoked a pack of cigarettes daily for the past 40 years and occasionally drinks alcohol. Orthostatic vitals signs are normal. ECG shows normal sinus rhythm. Doppler ultrasound evaluation of left vertebral artery reveals a retrograde caudal flow instead of normal anterograde flow. Note this point. Which of the following arteries is most likely to be occluded based on these ultrasound findings? Option A, innominate artery, B, left internal carotid, C, left internal memory, option D, left subclavian, and option E, right vertebral. Pause it and give the answer. So the correct answer for this question is left subclavian artery, because it is the example of left the coronary syndrome. This is the example of left subclavian steel syndrome, right? We will talk about this thing. So what would happen? Let's say this is the brachiocephalic trunk, right? Or this is the aortic arch, right? And this one is left common carotid, right? And with that we have this left subclavian artery, right? So if let's say there is a severe stenosis of the left subclavian artery, what would happen? This will like let's say the blood should move from here to in opposite in this direction, anterograde. But in this case, in subclavian steel syndrome, this will pull the blood from this vertebral artery. This one is vertebral artery, right? From this vertebral artery in the retrograde direction, right? And if we move upward, we have basilar artery, then we have vertebral artery, right? So the flow would become in retrograde direction, right? Okay, this patient presentation is consistent with subclavian steel syndrome, which typically occurs due to hemodynamically significant stenosis of the subclavian artery proximal to the origin of vertebral artery. This is important. Proximal to the origin of vertebral artery, right? They mean to say this will be proximal to the stenosis will be proximal to the origin of vertebral artery, right? Subclavian stenosis is typically caused by atherosclerosis, although less common etiologies include Takayasu arthritis and complications from heart surgery, for example, aortic coarctation repair. The lower distal subclavian artery pressure leads to reversal in blood flow from the contralateral vertebral artery to ipsilateral vertebral artery. That means on the same side. If stenosis is on this side, so the blood flow will be on this side in retrograde direction, away from the brainstem, basilar artery, right? In those areas. Most patients with subclavian artery stenosis are asymptomatic. When symptoms occur, they are typically related to arm ischemia in the affected extremity. For example, exercise induced fatigue, pain, and paresthesias, or vertebro basilar insufficiency, right? Just like in this case, dizziness, vertigo, drop attacks. Physical examination can show a significant difference greater than 15 mm of mercury in brachial systolic BP between the affected arm and normal arm. This is important. Doppler ultrasound of the cerebrovascular and upper extremity arterial circulation establishes the diagnosis of most patients. Why not option A? Although innominate, that is brachiocephalic artery stenosis or occlusion can cause subclavian steel syndrome. Patient with significant occlusion would develop a retrograde flow to the right vertebral rather than left, because that is on the uh, right side. Okay. Why not option B? Internal carotid artery occlusion may occur due to thrombosis or embolism leading to transient ischemic attack or ischemic stroke. Patients typically would have profound neurologic deficits, that is contralateral homonymous hemianopsia, hemiparesis, hemisensory loss, right? Those things, including cortical signs, aphasia, agnosia, neglect. Blood flow reversal in the vertebral artery is not characteristic. Yeah. Why not option C? Coronary subclavian steel phenomena occurs in patient with prior coronary artery bypass. So there should be prior bypass surgery. Okay. Using the internal memory artery, IMA, similar to that of subclavian steel syndrome, blood flow through the IMA can reverse and steel flow from the coronary circulation during increased demand upper extremity exercise. However, symptoms are typically related to coronary ischemia, that is angina pectoris. Okay. Right vertebral artery occlusion usually leads to ischemic stroke or transient ischemic attacks and can cause similar symptoms as seen in this patient. However, Occlusion of the right vertebral artery would cause retrograde flow on the right versus the left, and symptoms are not typically precipitated by the arm exertion, right? So, subclavian steal syndrome occurs due to severe stenosis of the proximal subclavian artery, which leads to reversal in the blood flow from the contralateral vertebral artery to the ipsilateral vertebral artery. Right? Patients may have symptoms related to arm ischemia. This is important in the affected extremity. Right? Exercise-induced fatigue, pain, paresthesias, or vertebrobasilar insufficiency. For example, dizziness and vertigo. Okay. Now, question number 14 of 70 old man comes to the emergency department due to severe mid-back pain. Um mid-back pain that started several hours ago. He describes the pain is excruciating and wants immediate relief. The patient also has nausea, diaphoresis, and lightheadedness. He has a history of hypertension and CKD. His medication compliance has been poor. He is an active smoker with a 40 pack year history. His BP on the right arm is 220 by 105 mm of mercury. ECG shows sinus tachycardia and voltage criteria for left ventricular hypertrophy with with secondary ST segment and T wave changes. After initial evaluation, a transesophageal echocardiogram shows dissection flap in the descending aorta, but no evidence of dissection in the ascending aorta. The dissection flap in this patient most likely originates near which of the following points? Option A, brachiocephalic trunk. Option B, celiac trunk. Option C, intercostal arteries. Option D, left subclavian artery. Option E, renal artery. Pause it and give the answer. So the correct answer for this question is uh, option D, left subclavian artery. Okay, let us see to the explanation. Now, this patient's clinical presentation with severe back pain, hypertension, ECG abnormalities, and transesophageal echocardiogram, finding of dissection flap in the descending aorta, consistent with Stanford type B aortic dissection. Right? The Stanford system uses the anatomic location of the dissection plan for classification of aortic dissections. Right? Let us explain this. Like we have Stanford type A, which refers to the aortic dissection that involve any part of the ascending aorta, right? Any part of the ascending aorta, right? Then we have Stanford type B, refers to the all other dissection involving the descending aorta, right? Once again, type A aortic dissection involve any part of the ascending aorta, so only our ascending aorta. Type B uh, involving descending aorta. Okay, all other dissections with that involving descending aorta, right? Type B dissections involving the descending aorta typically originate close to the origin of the left subclavian artery, right? If we look at that, this one over here is the aortic arch, brachiocephalic trunk, right? Then we have left common carotid artery. Then we have left subclavian artery. Over here, this flap is present, so near to the subclavian artery. They're talking about this. In type A, that involve only ascending aorta. The problem is over here, like you can see over here. Okay, then we have type B. Problem is in the descending aorta, right? And the problem over here is intima, and this will move in between the dissection, that, that is media, right? And then the last one is adventitia. So the problem is in between intima and media, right? Now, type A aortic dissection usually originate in the sinotubular junction. The areas are thought to be predominantly affected due to increase in the rate of rise of pressure, del P upon del T, and ensuring forces at the site in patient with severe hypertension. Why not the other options? Distal propagation of type A dissection or proximal propagation of type B dissection can affect the aortic arch, right? For example, brachiocephalic artery, left common carotid artery, and left subclavian artery. Either type of dissection can propagate distally into the thoraco-abdominal aorta, involving the origins of the celiac trunk, intercostal arteries, and renal arteries. So the intimal tear of the stand for type aortic dissection involving the ascending aorta, usually originates in the sinotubular junction. This is important. Whereas the intimal flap in the stand for type B aortic dissection usually starts near the origin of the left subclavian artery. Dissection can propagate distally to thoracoabdominal aorta. Okay, next question. A 23-year-old previously healthy man is brought to the emergency department after a step injury. Okay, his friends report that they were walking down the street minding our own business when a guy jumped out in front of us from behind a dumpster and stabbed him in the chest. Okay, stabbed him in the chest. They were able to disarm the man after this single attack, and the man then ran off into an alley. The patient is conscious but is in distress. Physical examination shows laterally directed anterior chest wall stab, okay, uh, wound at the fifth intercostal space. This is important, fifth intercostal space, right? Along the left metaclavicular line, pointing toward one important point, okay? We'll talk about that. Which of the following is most likely to have been injured in this patient? Esophagus vein, inferior vena cava, left atrium, left lung, and right ventricle. So, what do you think? The correct answer would be which thing? This one, or this one? So, the correct answer for this is this. Let us see to the explanation why, right? Because over here, like if we came over here mid clavicular line in the fifth intercostal space, so we have lung, right? And we have the left ventricle, but they have not mentioned in this case left ventricle, so the answer is left lung, right? So a penetrating laterally directed step wound, possibly from the left-handed assaulter. This is also pointing to one important point: left-handed assaulter. They involve the fifth intercostal space at the left anterior midclavicular line, would be most likely injured the left lung, right? The lungs occupy most of the volume of the thoracic cavity. The apex of each lung extends into the neck about the first rib, 3 to 4 centimeter. The lung bases are in direct contact with diaphragm, which separates the right lung from the right lobe of the liver, and the left lung from stomach, spleen, and occasionally left lobe of the liver. Okay, the mediastinal surface of each lung has a cardiac impression that accommodates the heart. A deeper and more medially directed wound could have injured the left, not the right ventricle. Right. The heart is located behind the sternum and its interior surface is partially covered by the lungs. This is important. The cardiac apex is formed by the left ventricle, about which I was talking, right? Depending on the heart size, the point of maximal apical impulse can be felt at the fifth intercostal space between the fifth and sixth ribs at the left midclavicular line. All other heart chambers, including the right ventricle, lie medial to the left midclavicular line and unlikely to have been affected by the injury. The right ventricle forms the sternocostal interior surface of the heart, so this couldn't be the answer. The diaphragmatic, that is inferior surface, is formed by the left and right ventricles and in contact with central tendon of the diaphragm, right? The posterior surface of the heart is formed mainly by the left atrium, so that is posterior, right? Not interior, okay? Because the attack is done from interior side. The azygous vein lies in the posterior mediastinum, immediately to the right of the midline. It drains blood from the posterior intercostal veins into the superior vena cava. Option B, inferior vena cava, located in the mediastinum, lies to the right of the midline, drains to the right atrium. Okay, so the left ventricle forms the apex of the heart. It can reach as far as the fifth intercostal space at the left midclavicular line. All other chambers of the heart lie medial to the left midclavicular line. The lungs overlap much of the interior surface of the heart. So your question is resolved. Okay. Now moving to question number 16. A 52-year-old man is being evaluated for non-specific chronic abdominal pain. As part of the workup, he undergoes an abdominal CAT scan with IV contrast, which reveals no significant finding. An axial image from the scan is shown below. Okay, let us see. So they have mentioned this thing, right? Let me show this thing for you. This is liver, right? Right. Okay, this is stomach, but they are asking about one point in the red arrow, right? Okay, let me further explain this for you so that you could got this. right? This is abdominal aorta, right? This one is pancreas. This one is left renal artery, and this one is right renal artery. Now you can answer this, right? Okay. So they're asking which of the following statement best describe the structure indicated by the right arrow? Okay. Option A drains into the left subclavian vein in the thorax. Option B drains through the cystic duct into the common bile duct. It gives to the right and left renal arteries. Option. So then we have um, option D. It is found by the union of common iliac arteries. Common iliac veins. Option E. It joins the splenic vein to form portal vein. So pause it and give the answer. The correct answer for this question is option D. Yeah. Why? Let us see. Okay. Because they will drain into the inferior vena cava. This is the structure of inferior vena cava, right? Okay. So as I was saying, this is the structure of inferior vena cava, right? This is the aorta, right? This is left renal vein. This is right renal vein. This is right renal artery, right? Okay, this is left renal kidney. Sorry, this is left renal kidney. This is left renal kidney. This is right renal kidney. Okay, and as I mentioned, this is liver. Okay, with that we have stomach. This one, right? And this one is pancreas. Okay. So this axial CT image reveals the abdomen near the level 1, that is L1 uh, vertebral level. At this level, the inferior vena cava lies just anterior to the right renal artery and to the right of the aorta. Right. The inferior vena cava is formed by the union of right and left common iliac veins at the level of L4, L5 and drains into the right atrium just above the level of diaphragm at T8. The inferior vena cava returns venous blood to the right atrium from the lower extremities, portal system, abdominal and pelvic viscera. So these things are important: lower extremities, portal system, abdominal and pelvic viscera. The thoracic duct drains lymph from the entire left side of the body in all inferior to the in all regions inferior to the umbilicus, including the entire GI tract. Okay, it enters the thorax through the aortic hiatus and empties into the left subclavian vein near its junction with internal jugular vein. The cystic duct drains bile from the gallbladder into the CBD, that is common bile duct. The gallbladder is typically visualized just below the liver, in the interior right abdomen, but is not well seen in this image, right? The image reveals the abdominal aorta in option C, okay, giving rise to the right and left renal arteries. Right and left renal arteries at the level of L1. The abdominal aorta lies posterior medial, right, to the inferior vena cava within the abdomen. The superior mesenteric vein joins the splenic vein to form portal vein, right? The portal vein can be seen vaguely near the head of the pancreas in this cross-sectional image, right? So the inferior vena cava is formed by the union of right and left common iliac veins at the level of L4, L5, right? The renal arteries and veins lie at the level of L1. This is important. Common iliac veins, they're formed at the level of the union of right and left common iliac veins at the level of L4, L5, while the renal arteries and veins at the level of L1, right? The inferior vena cava returns venous blood to the heart from the lower extremities, portal system, abdominal, and pelvic viscera. Okay, now question number 17. A 71-year-old man comes to the hospital due to 3 hours of persistent retrosternal chest pain and dyspnea. After prompt evaluation, he is diagnosed with acute MI and undergoes cardiac catheterization. During cannulation of the right common femoral artery, the arterial wall is penetrated superior to the right inguinal ligament. Superior to the right inguinal ligament, right? Percutaneous coronary intervention is then performed, after which firm pressure is applied to achieve hemostasis. Soon after the procedure, the patient becomes cold, clammy, and hypotensive. Physical examination shows a 5 centimeter region of ecchymosis surrounding the femoral puncture site. Internal bleeding is suspected. Which of the following most likely location of this blood collection? Pelvic cavity, retroperitoneal space, right, paracolic gutter, subcutaneous tissue, thigh muscles. Pause it and give the answer. So the correct answer for this question is retroperitoneal space. Okay, so let us see to the explanation. Why? Vascular excess during the cardiac catheterization is typically obtained through either the common femoral artery or radial artery. Note this point, right? Common femoral artery or the common femoral artery is the continuation of external iliac artery. Let's say this is the um, inguinal ligament. Above would be external iliac artery. Below that inguinal ligament, that would be what? Common femoral artery, right? So, the common femoral artery is the continuation of the external iliac artery. It crosses the inguinal ligament. Arterial puncture above the inguinal ligament increases the risk of retroperitoneal hemorrhage. Right? Is this portion of the vessel lies directly inferior to the peritoneum? Right? Directly inferior to the peritoneum. Accidental puncture of the posterior wall can cause blood to track along the loose connective tissue surrounding the vessel and accumulate within the interfacial planes of retroperitoneum. Bleeding in the retroperitoneal space cannot be controlled um, with external compression and can lead to life-threatening hemorrhage. Affected patients typically develop hemodynamic instability with significant hypotension, drop in hemoglobin, absolute flank pain. Important. This is important, right? One option A, bleeding into the pelvic cavity is frequently due to trauma like pelvic fracture or gynecologic hemorrhage, ruptured ectopic pregnancy. Injury to the common femoral artery uh, less likely to cause intraperitoneal bleeding. Is the external iliac artery courses underneath the peritoneum, right? One option C, uh, the right paracolic gutter is peritoneal recess found between the ascending colon and abdominal wall. Fluid, for example, bile, pus, typically accumulates there from pathology involving the GIR, particularly the appendix in gallbladder, right? Why not option D? The subcutaneous tissue hemorrhage from the arterial source typically presents with large area of ecchymosis and palpable hematoma. Development of significant hypotension is less likely with subcutaneous bleeding. Is the potential space for blood accumulation is smaller with peritoneal or retroperitoneal bleeding. Okay. One option E, hemorrhage into the thigh muscles would present with significant pain and edema in thigh, possibly lead to compartment syndrome, severe pain, absent distal pulses. The optimal site for obtaining vascular access in the lower extremity during cardiac catheterization is common femoral artery, below the inguinal ligament, not above, right? Cannulation above the inguinal ligament can significantly increase the risk of retroperitoneal hemorrhage. This is important. Moving to question number 18. We have a 53-year-old man is hospitalized due to chest pain and palpitation. Cardiac catheterization is planned to evaluate for coronary artery disease. The femoral artery is palpated in the right groin. Okay, and a catheter is introduced into the common femoral artery, which is generally done okay, in that case, the associated vasculature is visualized after injecting a contrast agent into catheter. So they're asking about this one, this one artery. Okay. So let me tell you this thing. Over here we have femoral artery, right? That is moving in the upward direction, right? That would become external iliac artery, and that would give this branch. They're asking about this branch. I have made up to that much easy for you. Now if you couldn't answer, it will be very bad. Okay. So they're saying which of the following is most likely artery indicated by the arrow in the image above. Okay. So inferior epigastric, internal iliac, medial circumflex femoral, obturator, and superior gluteal. Pause it and give the answer. So the correct answer for this question is inferior epigastric, right? Okay, let us see the explanation. So as I was saying, that external iliac artery, it would give a branch in the upward direction. That would be considered as in inferior epigastric artery, and that is continuing I mean to say, the external iliac artery would be continued in the downward direction and will form common femoral artery, right? Okay. So, as the aorta courses through the lower abdomen, it divides into the common iliac arteries, which subsequently branch into the internal and external iliac arteries. The inferior epigastric artery branches off from the external iliac artery, right? First thing, this is important. Immediately proximal to the inguinal ligament before the external iliac artery becomes the common femoral artery. That means if, let's say, this is the inguinal ligament, above this it would be external iliac artery. When it passes through that inguinal ligament, that then it would be form common femoral artery, but before that it would give a branch in the upward direction, but the name is inferior, right? So that is inferior epigastric artery, but moving superiorly, right? Don't confuse in that. Is the inferior epigastric artery runs superiorly, right, and medially up the abdomen. It provides blood supply to the lower interior abdominal wall, right? The other main branch of the external iliac artery is the deep circumflex iliac artery, which branches more laterally or also supplies blood to the lower abdominal wall, right? Both are supplying blood to the lower abdominal wall, but deep circumflex artery that would move laterally, but the inferior epigastric artery that would move medially, right? Why not the other options? The internal iliac artery supplies most of the structures of the pelvis, gluteal region, medial thigh. Which things? Pelvis, gluteal region, medial thigh. The obturator artery is the branch of the internal iliac artery that runs inferiorly to supply blood to the bladder, right? And with that medial compartment of thigh. Important. Internal iliac artery by itself, pelvis, gluteal region, medial thigh. Obturator artery, branch of that internal iliac artery that will supply bladder, medial compartment of thigh. The superior gluteal artery is the continuation of internal iliac artery. It runs inferiorly to supply the gluteal muscles and the portions of the hip. So portion of the hip with that gluteal muscles, but it is the continuation of the internal iliac artery. So two things to remember. Let's say this is inguinal ligament. External iliac artery that would give rise to femoral artery when it passes to the word what that is called yeah, inguinal ligament. But the internal iliac artery that would continue is what is what superior gluteal artery, right? Okay. So why not option C? Option C, the medial circumflex femoral artery. Medial circumflex femoral artery branches of the deep femoral artery to supply blood to the femoral neck. This is important. The femoral neck is supplied by the medial circumflex femoral artery, right? Okay. So the inferior epigastric artery branches off the external iliac artery immediately proximal to the inguinal ligament. It provides blood supply to the lower interior abdominal wall. As it runs superiorly and medially up the abdomen, right? Now, question number 19. A 4-year-old boy is being evaluated for failure to thrive, shortness of breath, exercise intolerance. The parents first became aware of his symptoms after the patient started preschool a few weeks ago. His teacher mentioned that the patient seemed to beat tap faster than the other children when playing outside. Cardiac examination shows bounding peripheral pulses and a palpable thrill below the clavicle near the left upper sternal border. Remember this point, right? Below the clavicle, right? And left upper sternal. On auscultation, continuous murmur. Again, point this. Okay, remember this point. Is best heard over the same region. After discussion with the parents, a thoracotomy is scheduled to correct the patient's condition. During the procedure, the surgeon should plan or unligating a derivative of which of the following embryologic structures: bulbous cordis, fourth aortic arch, primitive apia, sinus venosus, and sixth aortic arch. So I think this is option E. Yeah, let us see to the explanation why. So if we look at the aortic arch and their adult derivatives, the first that would give rise to part of maxillary artery, the second that would give rise to hyoid artery and stapedial artery, the third one, this is important, they have given this MCQ, the third that would give rise to common carotid artery. Note this point, we will discuss this in an MCQ. The third is proximal internal carotid artery, right? So this thing is derived from third artery, right? We will talk about that. The fourth on the left side it would give rise to aortic arch, while on the right side it would give rise to proximal right subclavian artery. This one has also came in as an MCQ. We would talk about this, right? But in this case is they have mentioned the sixth, right? That would give rise to proximal pulmonary arteries, right? And on left, ductus arteriosus. Now they have mentioned this case of ductus arteriosus. Let us see to the explanation. Okay, so this patient most likely has parent ductus arteriosus, that is PDA. The ductus arteriosus is an embryonic derivative of sixth aortic arch. This is important, that allows fetal blood to pass directly from the pulmonary artery to the proximal descending aorta, bypassing the pulmonary circulation. This vessel usually closes shortly after birth, secondary to decreased prostaglandin E, right, levels and increased oxygen concentration. Patency of ductus arteriosus after birth results in the left to right shunt, right, left to right shunt, that can cause left ventricular volume overload. So left ventricular volume overload and symptoms of heart failure, right? And that is in this case failure to thrive, respiratory distress. Physical examination will show continuous machine-like murmur that is associated with the PDA, right? Machine-like murmur is associated with PDA. Remember, this is important MCQ. And palpable thrill over the left infraclavicular region due to the turbulent blood flow to the PDA. A pharmacologic closure of a PDA can be achieved by prostaglandin E2 synthesis inhibitors, for example, endomethacin, acetaminophen, etc. We can also use those things and premature infants, right? However, older patients usually require surgical ligation or percutaneous PDA occlusion, right? Why not option A? The bulbous cordus forms the beginning of the ventricular outflow tract in the embryonic heart. The structure forms the smooth part of the left and right ventricles adjacent to the aorta and the pulmonary artery, respectively. Right? So they will form smooth portions. For example, let's say let me draw this for you guys. Okay, let's say over here the smooth part of the outflow tract, that is pulmonary artery and for aorta, that would be formed by this bulbous cordus, right? Good. The fourth aortic arch on the left would form arch of the aorta, right, between the left carotid and the ductus arteriosus. Abnormalities during development can result in coarctation, narrowing of the aorta. As I was mentioning this, that they have given this MCQ, we would talk about this. So that would give rise to coarctation of aorta, which can present with continuous murmurs over the back due to collateral formation, right? We would talk about that. The primitive atrium receives blood from the sinus venosus in the embryonic heart and transmits it to primitive ventricle. The primitive atrium forms the rough portion of the left and right area, and just like that, the primitive ventricle would form the rough portion of right and left ventricle, right? The sinus venosus is an embryologic structure within the heart, receives blood from the vena cava. In adult, this structure forms a smooth portion of the right atrium, right? That is known as sinus venerum, right? So the ductus arteriosus is derived from the sixth embryonic aortic arch. A PDA, that is parent ductus arteriosus, causes left to right shunting of blood that can be heard as a continuous murmur over the left infraclavicular region. Really important. Endomethacin prostaglandin E2 synthesis inhibitor can be used to close PDA in premature infants, right? But surgical ligation is often necessary in older patients. The last question for today's session. We have a 68-year-old man with a history of permanent AFib comes to the office for follow. He has been having symptoms due to ineffective ventricular rate control despite aggressive medical therapy and examination. The patient's heart rate is 1 to 5 per minute and irregular. ECG shows AFib, that is atrial fibrillation, with rapid ventricular response. A catheter-based radiofrequency ablation of the AV node, atrioventricular node, with placement of permanent ventricular pacemaker is planned. Note this point, right? The ablation tape should be positioned at which of the following locations? They are talking about the location of AV node, right? Okay. So option A between the tricuspid wall and inferior vena cava opening. Option B interatrial septum near the opening of the coronary sinus. Option C left atrium near the opening of the pulmonary veins. Option D, posterior part of the fossa ovalis. Option E, upper part of the crista terminalis near the superior vena cava opening. Pause it and give the answer. And the correct answer for this question is option B, right? Because they are asking about the position of the AV node ablation, right? Now let us see to the explanation. So they are asking about the location of AV node, right, which is close to the coronary sinus and in the atrial septum, right? This is the right atria, this is the left atria, right? And this is the septum between them, right? So yeah, like we have inferior vena cava from below, and this is fossa ovalis from foramen ovale, right? And this is crista terminalis, above portion, right? And we have SA node, superior and lateral of the right side. Okay, so the AV node controls the rate at which atrial impulses are conducted to the ventricles. In patients with AFib, that is atrial fibrillation, continuous stimulation of the AV node can sometimes lead to rapid ventricular rate, which can cause hemodynamic instability and, if persistent, tachycardia-induced cardiomyopathy. In order to prevent these complications, patients with a rapid ventricular response sometimes undergo radiofrequency ablation of the AV node, right? So the AV node is located on the endocardial cushion of the right atrium near the insertion of the septal leaflet of the tricuspid wall and the orifice of the coronary sinus. Right? We talked about this. Why not option A and D? The isthmus between the inferior vena cava and the tricuspid annulus is the site of radiofrequency ablation for atrial flutter. Now this is important, right? That is the isthmus between the inferior vena cava and the tricuspid annulus is the site of radiofrequency ablation for atrial flutter. But this is AFib, atrial fibrillation, right? The fossa ovalis is the name given to the foramen ovale about which I talked now. Okay, fetal opening between the right and left atria once it is closed. However, neither option refers to the location of AV node. Okay, so the pulmonary vein uh, ostia are often the origination site of the aberrant electrical activity that triggers a fib, right? In catheter ablation of these trigger sites, pulmonary vein isolation can be used to prevent recurrent atrial fibrillation. That is used for recurrent, right? Atrial fibrillation. However, this patient has already developed permanent atrial fibrillation. So in this case, this is permanent atrial fibrillation and is undergoing an ablation procedure involving the AV node, right? Okay. Why not option E? The SA node, that is sinoatrial node, is located. Uh, okay, is located. Wait for a while. So the SA node is located in the upper anterior right atrium, in the opening of the superior vena cava, right? So the atrioventricular node is located on the endocardial surface of the right atrium near the insertion of the septal leaflet of the tricuspid wall and the orifice of the coronary sinus. I think it's enough for today. We have done it in less than 1 hour. So enjoy that.